Good morning. I'm Dr. Angela Leung, and this is Dr. Stephanie Smooke. We're from the Division of Endocrinology at UCLA, and we're so delighted that you can join us for this webinar regarding an underactive and an overactive thyroid. How do these impact me? Let's begin. For the audience that's listening and watching, please ask questions on Twitter using this hashtag that's shown on the screen. We'd be happy, and we have plenty of time at the end to entertain questions. This is a brief overview we'll be covering during the next 30 minutes. We'll briefly talk about what is the thyroid, then we'll review how does it work, and then really concentrate the bulk of our time on the underactive thyroid and the overactive thyroid. So very briefly, what is the thyroid? Well, the thyroid is this butterfly-shaped gland. It's located at the front part of the neck, shown exactly as you see here on the slide. There's different shapes in different people, but in general, it consists of a right-sided lobe, a little bridge called the isthmus, and then the left-sided lobe. And what it does, the thyroid is responsible for making our thyroid hormones. And what are thyroid hormones needed for? They actually are important for so many important things in the body. They are responsible for processes in the heart, in the brain, and then also in controlling muscle, but also in many other body systems as well. So I'm going to turn it over briefly to Dr. Smooke for the next part.
Thank you, Angela. So the next thing that we're going to go over is a little bit about how the thyroid works. And this can be kind of tricky because sometimes it's counterintuitive as to what we may think. But the thyroid is really under control of the pituitary gland, which is the hormone control center that sits right in the middle of the brain. And the pituitary gland's job is to produce a hormone called TSH, or thyroid stimulating hormone, that acts on that little butterfly-shaped gland that Angela just talked about on the front of the neck in order to stimulate it to produce two hormones. And those hormones are T4 and T3. T4 is a longer-acting thyroid hormone, and it's about 80% of what's produced by the gland. And T3 is a much shorter-acting hormone, and it's about 20 to 25% of what's produced. And out in the body, T4 changes into T3, and that T3 goes out and does the work of the thyroid. Now, in order to regulate itself, the T4 and T3 feed back to the pituitary in order to maintain the TSH in a normal range, which is considered to be between 0.5 and 4.5. Now, sometimes those systems don't work properly, and in hyperthyroidism, we can get an overproduction of T4 and T3, and that has negative feedback at the level of the pituitary gland and causes the TSH to go down. So this is sometimes a little bit tricky, but an overactive thyroid leads to a low TSH. On the other hand, in hypothyroidism, we have a condition where we don't have quite enough of these hormones, and we're going to talk more about the reason for that. And in that case, those hormones communicate back to the pituitary, and they stimulate the TSH to go up in an effort to produce more hormone. So in hypothyroidism, the underactive version, we have a high TSH. Now, how do we evaluate how the thyroid is working? Well, your doctor will take a history from you, focusing in on some of the systems that are affected by the thyroid. They'll do a physical examination and then order blood tests. In terms of the history, your doctor is going to focus in on body systems and symptoms that might be produced by the systems that are impacted by thyroid function. So some of those include your energy levels, your bowel function, metabolism, the way that your body is sensing temperature, mood, and in women, your menstrual cycle. On the physical examination, your physician will focus in on vital signs, including blood pressure and heart rate. They will examine your thyroid. They'll take a look at your skin, your reflexes, and assess you for any swelling. In terms of laboratory tests, which ones is your doctor going to check? For most thyroid tests, they're going to do a TSH, and we'll talk a little bit more about why that's such an important test. And then they may check free or total T3 or T4 hormones. Now, why is TSH the test that we start with? TSH is thought to be our optimal screening test because there's what's called a negative log linear relationship between T4 and TSH. And what that means is that really small changes in T4 hormones can lead to big swings in TSH. So TSH gives us an idea when things are happening in the thyroid, even if they're just a little bit off from normal. So that it gives you a little bit of information about what the thyroid is and how it works. And now we're going to move into a little bit of discussion about that underactive thyroid gland. So again, we come back to our diagram where we see the pituitary producing the TSH that acts on the thyroid. The thyroid produces hormone, and then the pituitary is interpreting what it senses. And again, in low levels of T4 and T3, there's positive feedback at the level of the pituitary, and the TSH is going to elevate. So what are some of the causes of thyroid dysfunction? Well, these can be split up into what we call primary causes and secondary causes. Primary causes are things that impact the thyroid itself. Secondary causes are things that impact the systems that are controlling the thyroid, namely the hypothalamus and the pituitary. So some problems that can occur with the body of the thyroid itself include an autoimmune process called Hashimoto's thyroiditis. It can occur if you've had surgery to remove part or all of your thyroid. It can occur after treatment with radioactive iodine. And then there are also congenital causes or things that you're born with that can impact the function of the thyroid. There can also be problems with production of thyroid hormone, and those can include things like iodine deficiency, or enzyme defects, again, that somebody could be born with, or it could be impacted by different drugs that you're taking to treat other conditions. In terms of secondary causes that can impact the thyroid, that involves decreases in secretion of either TRH, which comes from the hypothalamus, or TSH, which comes from the pituitary. At the level of the hypothalamus, there can be tumors such as lymphomas or germinomas. There can be infiltrative disorders such as sarcoidosis, hemochromatosis, or histiocytosis, among others. And at the level of the pituitary, again, there can be tumors or mass lesions. We could have dysfunction in patients who have undergone pituitary surgery or irradiation treatment. There's a condition of hemorrhagic apoplexy, which means bleeding into the thyroid gland, called Sheehan syndrome, or an entity called lymphocytic hypophysitis, which is an inflammation of the stalk over which the hormones travel in and out of the pituitary. So what might you feel if your thyroid's not functioning well? Some people have lots of symptoms. Some people find that they don't have any symptoms when they're diagnosed with a thyroid issue. But the symptoms that you might feel could include weight gain, a feeling of being more sensitive to cold or cold intolerance, a slower heart rate, more sluggish bowels, a decrease in energy, maybe a decrease in your mood. People might also experience some changes in their hair and hair loss. Women might notice that their periods aren't as regular or that they're having difficulty getting pregnant or maintaining a pregnancy. And some people might develop symptoms of carpal tunnel syndrome. In terms of signs on physical examination, you might have drier, coarser skin. You might experience some puffiness of your face, hands, or feet. There might be what we call pretibial myxedema, which is a non-pitting edema. Again, hair loss, some brittleness in your nails. Some patients might have bradycardia or a slower heart rate. And they could have diastolic hypertension, which is an elevated lower number on your blood pressure. Some patients may have some slower relaxation of your reflexes. And on the thyroid examination, we might see that the thyroid is normal. It could be bigger than usual, or it could be smaller than usual. So once your doctor has reviewed your history and gone through your physical examination, the next thing that they'll do for diagnosis is some laboratory testing. And again, we start with that TSH level because it is the most sensitive number in terms of shifting thyroid hormone in your body. And additional testing might include a free T4 level and tests for thyroid antibodies in order to diagnose Hashimoto's thyroiditis. And finally, your exam may or may not include a thyroid ultrasound, depending on what your doctor has noted on physical examination. So a question that we're frequently asked is, what do positive antibodies mean? And positive antibodies could be a thyroid peroxidase antibody or a thyroglobulin antibody. And those define Hashimoto's thyroiditis. And what that is it's a condition wherein antibodies exist against the thyroid that may impact thyroid function over time. Some patients might even have a little short-term hyperthyroidism, followed by either normal thyroid function or low thyroid function. But the important thing to remember is that the number of people with Hashimoto's antibodies far exceeds the number of people who actually have low thyroid function. So even if you've been diagnosed with antibodies, your thyroid may still continue to function normally. So once you've been diagnosed with low thyroid function, the next step is treatment. And our goal in treatment is to normalize thyroid hormone levels to alleviate signs and symptoms of hypothyroidism. We do this with several different types of medication, and I'm going to talk about two major types today. The first involves T4, and again, that T4 is a replica of what your thyroid is not able to produce well enough on its own, and it's quite a long-lasting hormone. So when your medication reaches a steady state in your body, it's going to hang around for about 7 days. Now, there are a bunch of different types of these medications, and I'm going to show you here we have some of the generic medications like levothyroxine, and branded medications are Levothyroid, Synthroid, and Levoxyl. And all of these function very similarly in your body. You might find that there could be little differences in how your body is absorbing them or how they're impacting your thyroid tests. So if you're switching back and forth from one to another, your doctor might want to check your thyroid levels after a change. The other medication that we have listed here is Tyrosint, and this is a newer medication that we found to be pretty effective in patients who have history of celiac disease, so they have an allergy to gluten or they have lactose intolerance, because this medication doesn't contain any celiac products or lactose. You might have also heard about another set of medications, which are T3 medications. And again, this is the hormone that is produced in a smaller amount by the thyroid gland and also is converted from T4 in your body. And when you're taking this, the half-life of this medication or how long it lasts in your body is much shorter. So you might have to take this medication every 8 hours in order to maintain a steady state. The generic form of this medication is called liothyronine, and the brand that you might have seen is called Cytomel. Now, after starting medication, your physician will recheck your blood work anywhere from about 8 to 12 weeks after a change. And there can take a little bit of time before the TSH catches up with your level of treatment. Now, the other important thing to remember is that the thyroid medications are a little bit finicky. So we want to make sure that we're taking them properly in order to ensure that they're going to have their best efficacy. So what we recommend is that you take your medication on an empty stomach, and that can either be 30 to 60 minutes before eating, or it can be 3 to 4 hours after eating. So you should discuss with your doctor whether you're planning on taking them in the morning or whether you would prefer to take them at bedtime. The other thing to remember is that there are some substances in the body that can impact how your medication is absorbed, and those include calcium, iron, fiber, multivitamins, and soy products. And if you're taking supplements that contain any of those entities, it's preferred to take them about a 4-hour distance away from your thyroid medication. Now, one of the questions that we're asked frequently is, what if my thyroid levels are normal, but I'm still having symptoms? And this is probably one of the tougher things that we confront when we're trying to help our patients. And in this case, we have to remember that in order to blame things on the thyroid, our symptoms really have to match up with our thyroid levels. So if you're having symptoms that seem like thyroid symptoms, but the levels are normal, then the next step is for you and your physician to work through and see if you can come up with other reasons that that may be happening. So to finish up on hypothyroidism, just a reminder that hypothyroidism is a state of having an underactive thyroid that doesn't make enough hormone. The diagnosis is made based on history and physical exam and laboratory testing. And the treatment of hypothyroidism involves taking medication that replaces what the thyroid is not able to do on its own. So with that, I'm now going to hand back over to Angela for a discussion of the overactive thyroid.
All right, so we're going to switch gears completely and move to the situation of what happens when the body is actually making way too much thyroid hormone in contrast to way too little. So hyperthyroidism is that, and it again is when the thyroid is overactive, too much thyroid hormone is being made. And as a result, as you can imagine, every sort of body system is revved up. Everything speeds up because metabolism is increased, and the body actually fatigues quite easily as a result. It's unable to compensate usually. And why are we concerned about having too much thyroid hormone? Why can't we actually have sort of this increased metabolism and this increased state of being revved up? Well, it's more of a concern over the long term. If you have a little bit of excess thyroid hormone, the primary concerns are bad effects of having too much thyroid hormone on the heart. And people with this situation can develop sort of a racing heart rate. The heart is sort of pushed too fast, so you can develop arrhythmias. And then secondarily, you can also have weakened bones or bone loss because there's too much metabolism, and this can result in something called osteoporosis. Now, what are the symptoms of hyperthyroidism or having too much thyroid hormone? It's as you can expect, it's the opposite of hypothyroidism. So in contrast, you would have too much energy. The person might feel some anxiety. They might have weight loss that is unintentional. As we spoke of previously, your heart rate can be very, very fast. Sort of a racing heart rate is what's described. Your stools can be very loose, or you can have diarrhea. You're easily sweaty. Your hair can be easy to fall out. This feeling of being hot all the time is very, very common. In addition, on exam, you might have some shakiness or tremors that you can't control. Trouble sleeping as a result of that, and your skin is always very warm and moist. And we'll talk a little bit about one particular type of hyperthyroidism in the next few slides. But in this particular type of hyperthyroidism called Graves' disease, some people can actually have their eyesight affected as well. And so this might manifest in the symptoms of red eyes or bulgy, bigger eyes, this feeling of grittiness, like your eyes are always very, very itchy, or you can have some double vision. So causes of hyperthyroidism, let's go through those. By far, the most common cause of hyperthyroidism is something called Graves' disease, accounting for at least 70% of all causes. And it really is an autoimmune disease in which the entire thyroid gland produces a little bit too much thyroid hormone. In contrast, the second probably most common cause is something called toxic thyroid nodules. And there's many, many other names for toxic thyroid nodules. Sometimes they're called hot nodules or autonomous nodules. And it's a situation in contrast to Graves' disease in which the entire gland makes too much thyroid hormone. In toxic thyroid nodules, only one particular part and something called a little bump or a nodule is responsible for making too much thyroid hormone. And you can have more than one nodule in any one gland, but this is just an example of one nodule. Other causes of hyperthyroidism, you can have some inflammation of the thyroid, and this is known as thyroiditis. Usually this is temporary, in which the thyroid is inflamed from many, many different causes, and it does self-resolve, but sometimes it does stay and hang around. And this results from leakage, usually, of preformed thyroid hormone. So the thyroid has already made its store of hormone, but for some reason, there's a lot of inflammation and out leaks the preformed stores. Now, these causes of hyperthyroidism are a little bit more rare, but they're actually not uncommonly seen. And one of them is excess iodine exposure. We didn't talk a little bit about what iodine does, but it essentially is a substrate. It's required for making thyroid hormone in the body. Primarily, the source of iodine is through the diet, but sometimes we're exposed through other things, sort of in medicine, that contain a lot of iodine, things like iodinated CAT scans or cardiac catheterizations. And these things are very necessary for imaging that you might require for other problems. But as a result, that excess exposure to a lot of iodine all at once wants the thyroid to suddenly make excess thyroid hormone. Iodine is also naturally found in kelp, or people can find it in iodine supplements, and this poses an increased risk for developing hyperthyroidism for the same reason. And there are also some smaller causes that are much more rare, but they're also possible. And if the preceding 4 causes don't seem to sort of make sense between you and your physician, your doctor might explore some of these other causes as well. So I wanted to concentrate a little bit on Graves' disease just because it is by far the most common cause of hyperthyroidism. It actually is the most common cause both in the US also, but worldwide. And what it is an autoimmune disease in which there are antibodies that are in the bloodstream. And these, sort of travel in clusters in certain families. And what they do, shown in the green in this diagram, is that they sort of stimulate the thyroid cells to sort of turn on the thyroid in a perpetual state to make excess thyroid hormone all the time. So with all other autoimmune diseases tend to travel together. So you or family members might also note a history of other diseases sort of more frequently than the general population. Things like type 1 diabetes or celiac disease, Addison's disease, which is a disease of the adrenals, or vitiligo, which is whiteness of the skin, hypopigmentation. Now, finding suggestive of Graves' disease, because it is an autoimmune disease, it's a little bit more special. Frequently, folks might complain and present with an enlarged thyroid. This is an extreme example that I've shown here in the picture, but this is something that we call a thyroid goiter. Again, folks might have eye disease that's involved in Graves' disease, and it's a result of those antibodies are stimulating both the thyroid as well as the eye. So you might have those eye symptoms that I spoke about previously, of the protrusion, the bulgy eyes, the itchy eyes, so forth. And then your doctor might also be asking about the presence of other autoimmune diseases, either in yourself or a close family member. Now, speaking a little bit more about Graves' eye disease, this is also known as Graves' ophthalmopathy. And it's a very specific sign and symptom of Graves' disease itself. Not everyone with Graves' disease will have this thyroid eye disease. Only a smaller percentage of them, folks will. But these are the symptoms again, and these are some more severe photos of what Graves' ophthalmopathy can look like. Interestingly, Graves' ophthalmopathy or thyroid eye disease, this is actually worsened by cigarette smoking. So oftentimes, if we find that Graves' disease is present in you, we counsel you to either quit smoking or at least decrease the amount of cigarettes use. And then folks with very severe or even moderate amount of thyroid eye disease, we can easily refer you to our colleagues who specialize in thyroid eye disease. Now, there's a special type of consideration for Graves' disease in pregnancy. And this is because there's increased risk of complications, both when you deliver the baby, but also for the newborn after birth if you have Graves' disease during pregnancy that's uncontrolled. These are some of the complications that can happen at the time of delivery. So miscarriage, preterm labor and birth. Your baby can be born with lower birth weight, stillbirth, or something called preeclampsia, which includes high blood pressure in the mother during pregnancy. And because there are some special implications for protecting your baby after delivery, but also at the time of delivery, you should talk about treatment options for Graves' disease if you are intending on becoming pregnant in the near future or currently pregnant, because those have some different implications of what we'll do. And then if indeed you have Graves' disease and you are pregnant, your doctor will work closely with you to make sure that the baby is as healthy as possible during the course of pregnancy. Okay, so how is hyperthyroidism or excess thyroid hormone diagnosed? We do it with a combination of blood testing and sometimes imaging. Mostly times we do use imaging in this situation. And this can include a thyroid ultrasound and a thyroid nuclear scan and uptake. I'll talk a little bit more about what those are in just a bit. So laboratory testing first. Just like hypothyroidism, The initial blood test that we always do is something called a TSH, a thyroid stimulating hormone. And this will be low in hyperthyroidism, just like Dr. Smooke talked about. But there are certain situations that can also lower the TSH. So that's actually needs to be teased out between you and physician to make sure this is really a true cause of hyperthyroidism. If the TSH is found to be low, we might do some confirmatory tests with measurement of the T3 and T4 that was previously discussed, and those should be high. And then if we're suspecting an autoimmune form of hyperthyroidism like the Graves, we might actually check and measure those thyroid antibodies in the bloodstream. And those can include TPO or thyroid peroxidase antibody and thyroid stimulating immunoglobulin or TSI. Now for imaging, the first and easiest sort of imaging that we can do, and usually right at the office in the same visit, is a thyroid ultrasound. It's using a very non-invasive, quick, painless probe that you see on your left to obtain this picture that you see here on the right. And again, we can see very easily the right lobe of the thyroid, that little bridge called the isthmus, and that left lobe to picture exactly sort of what is going on. If that's not able to, with combination of blood testing, able to arrive at a diagnosis of why you have hyperthyroidism, we might consider and recommend something called a nuclear scan and uptake. It's pretty useful for figuring out why you have hyperthyroidism because it's able to narrow down a lot of different causes very, very quickly. However, it's a sort of a different test. You can't do it right there in your office visit at the time you see your endocrinologist. You'd have to make an appointment to see a radiologist. And at that appointment, you would take a little small pill with radioactive iodine, a very, very small tracer dose. And then either 4 hours and maybe 24 hours later, you would come back and take a picture to see exactly where that dose went and traveled in your thyroid. Oh, okay. So now that we've diagnosed hyperthyroidism, let me review briefly about how we treat hyperthyroidism. There are sort of three major areas. Let me go back to this one. So this is pills, and these are just essentially medications. They're very, very effective to slow down the rate of thyroid hormone production coming from your thyroid gland. The examples that we have here in the US are methimazole and propylthiouracil, also known as PTU. If people take these medications for something called Graves' disease, that most common form of hyperthyroidism, you can achieve remission, which means that your disease is now controlled and you can stop the medication in about 20 to 30% of the time. However, these medications do have some risks like any medications do. And because of that, we only recommend that they be taken for a maximum of about 1 to 2 years. So 18 to 24 months is what's recommended. These are some of the side effects that can be seen. Rash actually is fairly common, but it's minor. And if it's tolerable, it may go away. More seriously, there could be liver damage. This third part, the low white blood cell count, is very, very rare. But if it happens, obviously that's impacting your immune system, and that can be very dangerous. Because of that, when people start these medications, methimazole and propylthiouracil, we counsel patients to immediately stop the medication if you have a high fever or the worst sore throat of your life, that to indicate that perhaps your immune system might be affected. And then again, if you're planning on becoming pregnant while you're taking these medications, it's important to discuss this point with your doctor for them to counsel you on specific indications for taking certain medications. Next, we have something called radioactive iodine treatment. And this is essentially a pill. It's a radiation pill, I-131, and here's a picture of what an I-131 pill might look like. It's taken orally in conjunction with a nuclear medicine physician. And over the course of the next several months, that radiation slowly kills off the thyroid gland that's making the excess thyroid hormone. It's not very fast, it's not very immediate, but over the course of several months, it can take effect to lower your amount of thyroid hormone. Because it is radiation, there's some safety precautions that are required in the first few days, especially after you take this pill. And so there's some isolation procedures that we can counsel folks on for the first sort of 3 to 5 days after you take this pill to not be around other folks and expose their thyroids to this radiation. There are some potential long-term effects of radioactive iodine. These are controversial, but sometimes we give you and treat you with the radioactive iodine to result in actually an underactive thyroid, because enough thyroid cells are killed permanently to not make the excess thyroid hormone, but this results in an underactive thyroid. And also, it's a little bit more controversial, but some folks think that this little bit of radiation, even though it's very, very small and it's targeted just for the thyroid, can result in another cancer sometime down the road in your life. And then the third type of treatment is thyroid surgery. This is usually reserved for folks who fail either the medications because they can't tolerate the medications or for some reason they can't do the radioactive iodine. It's best performed at a center by a surgeon with significant experience in the thyroid because there's potential damage to the parathyroid glands, which are located very close to the thyroid. And the parathyroid glands control the way the body uses calcium. Secondarily, there could also be damage to the vocal cords, which control your voice. So a potential complication of thyroid surgery might be hoarseness. However, in a very good center done with a surgeon who does a lot of these thyroid surgeries, the chance of both of these complications happening is usually less than 1%. And then obviously, if thyroid surgery is performed, the point is to take out your thyroid, remove the source of the thyroid hormone excess. This will result in permanent hypothyroidism, not having enough thyroid hormone. And again, you would have to take a thyroid hormone pill every day for the rest of your life. Okay. So in summary, that treatment part, the initial recommendation of which of the 3 types of treatment really depend on so many factors, and you should discuss this with your physician. It depends on your age. It depends on what the cause of the hyperthyroidism is, how severe your hyperthyroidism is at the present time, other medical conditions which might be present, including pregnancy or planned pregnancy in the near future, and then your personal preference. So almost at the end, but I wanted to give this one little tidbit, which is such a neat little fact, that hyperthyroidism or an overactive thyroid gland is actually the most common form of an endocrine disease in cats and your kitties. So you very well might have cats who are taking methimazole or propylthiouracil in the same fashion. And so in summary, for hyperthyroidism, it's a state of having too much thyroid hormone, an overactive thyroid. The most common cause for hyperthyroidism at about 70% of the time is something called Graves' disease. It's an autoimmune disease. The diagnosis of hyperthyroidism is made by a combination of these laboratory blood tests and then, if needed, some imaging. And the treatment are 3 options, either medication pills, radioactive iodine, or thyroid surgery. So thank you so much for listening. We're happy to take any questions that you fed in through Twitter. And I'll hand it over to Dr. Smooke, who might have a few questions already lined up.
So we have some excellent questions that have come in via the Twitter feed. And one of them is asking about someone whose mother has thyroid problems, and she's often feeling tired and having a sense of fatigue. And the person wants to know, when should she be worried? And can her primary care physician take care of the screening? And it's a great question. And the answer is absolutely. Primary care physicians can take care of the screening for thyroid disease. And if your family member has a history of thyroid issues and they're starting to develop some symptoms of either low thyroid function, which are, again, things like feeling cold and constipated and tired and more sluggish, or feelings of overactive thyroid that we just learned about, like feeling too warm or anxious and having the heart race and the bowels be too loose, the first step is to go into your primary care physician and have that TSH screened. And if your primary care physician feels comfortable, they can go ahead and manage. And if not, they'll refer you on to an endocrinologist for further evaluation. Another great question that we have on here is, are there any exercises or lifestyle behavior that you should adopt if you have hyperthyroidism or overactive thyroid? And this is a great question because, as we learned, thyroid hormones have an impact on muscle. So if you are in an active state of hyperthyroidism and you haven't been adequately treated yet, your doctor will probably recommend that you not do any vigorous exercise until the thyroid function is more normal, and that's because of the toll that it can take on your body and your muscles. So if you were to exercise when your thyroid function is overactive, you can actually have some breakdown of the muscle proteins, which can in turn, unfortunately, cause some problems for the kidneys.
Very good. There's some questions about the risk of radioactive iodine in causing another cancer sometime down the road. And so we talked a little bit about what radioactive iodine is. It is radiation, but because it's tied to an iodine molecule, the only role of iodine in the entire body, so nicely, is actually to go to only thyroid tissue. So because it's tied, this radiation, to iodine, it should really just target the thyroid gland in zapping away that excess thyroid hormone. But as you can imagine, radiation does sort of have a tendency to spread elsewhere. Most of it is excreted and gotten rid of from the body through the bodily fluid. So your sweat, your saliva, your tears, your urine in the first few days. And the bulk of it does remain, usually it should just remain in the thyroid gland. But they've done some large, long-term studies, and the risk of having a second cancer is potentially there, a little bit controversial, but if we had to choose the types of cancer that you might have a slightly increased risk for, it would be the blood types of cancer, so the leukemias. These are incredibly rare, way less than 1% for sure, but this is something that is continue to be debated and continue to be researched on. So great question. Another question that someone has sent in is, what are some of the best ways to prevent hyperthyroidism or hypothyroidism? This is actually a fairly common question, and mostly because so much of thyroid dysfunction, thyroid disease, it has an autoimmune nature. So some people sort of wonder, is there something I can do to prevent or at least decrease the amount of autoimmunity I have? Well, first of all, as Dr. Smooke had said, a lot of people have these thyroid antibodies that are really not impacting the thyroid function. So something called Hashimoto's thyroiditis that exists in about 15% of the general population. So if you do the math, that's 1 in 6 people who have these thyroid antibodies that, on the most part, are really not impacting you. But if you have these thyroid antibodies, at this present time, we actually don't know what progresses a certain person from having the antibodies to having an underactive or an overactive thyroid. So it's not really something that you can sort of proactively do to prevent the onset of this disease. What we can do is follow you very closely and use the right treatments in order to prevent the long-term consequences. Very, very common question, but I'm sorry I don't have a sort of a more of a concrete answer to that.
Can we give one pointer on the impact of iodine?
Oh, perfect. Yeah, this is a great segue into iodine.
So one of the questions that we get frequently asked is, should I be taking an iodine supplement in order to support my thyroid? And it's a little bit tricky because our body needs a certain amount of iodine in order to keep everything functioning the way that it should. But if you do have Hashimoto's thyroiditis, taking too much iodine can actually shut down your thyroid. So by taking kelp supplements or iodine supplements or some of the thyroid support supplements that you see at the pharmacy, those could get in your way more than helping you. In pregnancy, our body requires a little bit more iodine, so you want to check the labels in your prenatal vitamins and make sure that you're getting adequate daily dosing.
I wonder if we can just show the slides at this point. We have a couple slides regarding this. Again, iodine is essential for thyroid hormone production, and so both too much or too little iodine can actually shut down the thyroid and make you have thyroid dysfunctions. That's not a good idea. But I wanted to show you the recommendations for iodine intake If you're not pregnant, so this is sort of your normal, non-pregnant, not breastfeeding adult, 150 micrograms. If you are pregnant or breastfeeding, the baby that's growing inside of you or has just been delivered requires a little bit of iodine for themselves as well because their thyroid is not yet functional. So these are the recommendations: 220 micrograms a day for pregnant women, 290 for lactating women. And then in children, these are the recommendations, a little bit less, but 90 to 120. And a normal diet really should have enough, but if you are pregnant or lactating, especially since the baby doesn't have their own thyroid yet, and they require enough thyroid hormone for their brain function, really you should have enough there. And there are many multivitamins that contain various amounts that you can go around and shop for.
Okay. So with that, we want to thank everybody for their attention. We hope that you've learned a little bit about thyroid function and both the underactive and overactive thyroid glands. Have a good day.